Our next presenter is Dr. Alansari, peri-acute myocardial infarction, ventricular septal defect, percutaneous mechanical support choices.
Good morning, everybody. It's nice to be here. My name is Shehab Alansari. I'm one of the first-year cardiology fellows. Today I'm going to present a very interesting case that actually acted as a tremendous learning experience for me. So we start off with... I'm trying to change some. Oh, okay. Sorry about that. So we start off with the case, a 30-year-old male with a notable past medical history for hypertension, hyperlipidemia, acute myeloid leukemia, diagnosed at the age of 10, in remission, got radiation therapy. However, no history of radiation, cardiomyopathy as far as we knew. Presents to an outside hospital with a 1-week history of substernal chest pains. His EKG is actually very concerning, as you can all see. There are ST elevations in the inferior leads with reciprocal changes in the lateral. What's also concerning is that we can also see Q waves in the inferior leads, which perhaps suggest an subacute/delayed element of presentation. So he was hemodynamically stable, was a bit tachycardic, had cold extremities. His labs, his troponin was very high. He had features to suggest end-organ hyperperfusion with the AKI, the really bad transaminitis, LFTs in the more than 2,000, and lactic acidosis. So he subsequently rushed to the cath lab. So as you can see, the culprit here, there's a thrombotic occlusion in the proximal RCA. However, unfortunately, there was also multi-vessel disease, as you can see here in the LAD, as well as the left circ. So initially, the primary interventionist at that time was successful with the balloon angioplasty, however, had difficulties with the attempted thrombectomy. The reason being so is because of technical issue. His catheter was getting kinked, and also he was experiencing no reflow phenomena. Interestingly, when we did the LVogram, what you can see here is actually some shunting from the left to the right side. At that point, because the patient had evidence of metabolic cardiogenic shock, balloon pump was placed. As you can see here, this echo here shows his EF was preserved. There were no wall motion abnormalities. His RV was dilated and significantly impaired. What you can see here is there was a VSD at the base of the LV, measuring at that time roughly around 1.9 centimeters, with evidence of left to right shunting. The RV, again, here is dilated and dysfunctional because of that. He was then transferred to our hospital, and although he remained hemodynamically stable, his parameters of end organ was getting worse. His AKI got worse, his shock liver got worse, and his lactic acidosis continued to increase. So at that time, the decision was made to escalate his support. The balloon pump was removed, and then a tandem heart was placed. His LA pressures pre the tandem insertion was very high, 24. Right heart cath after the tandem insertion showed biventricular filling pressures that were normal. And his RA pressure was on the higher end. His cardiac index and output was very high in the setting of the VSD and left to right shunt. So our treatment strategy at this point was to support the patient until his end organ function improves and the VSD matures, followed by surgery, bypassing VSD. So fortunately, 48 to 72 hours later, the patient continued to improve. His LFTs, kidney function, and lactic acidosis. Well, his lactic acidosis cleared, his LFTs and kidney function continued to improve. He didn't require dialysis, he didn't require any pressors or inotropic support, and his oxygenation status remained minimal, was never intubated. 12 days post-admission, the patient experienced hemolysis, and at that point, we exchanged the pump. We repeated a TE at that point, and the VSD actually enlarged to 2.8 centimeters. 25 days post-admission, the gentleman got a 2-vessel cabbage, repair of the VSD, extraction of the tandem heart, and a placement of VA ECMO intraoperatively to kind of support him in the post-operative phase. He did very well. 7 days later, the ECMO was decannulated. He did require transient dialysis, but he was eventually discharged. So to kind of sum up things using the shock moniker, the variables, the severity was C, and then it progressed to D. His hemodynamic profile was interesting because although he was hemodynamically stable, he did have metabolic evidence of cardiogenic shock. Initially, it was used balloon pump. After that, we escalated to the tandem heart. The cause was AMI VSD. Our goal was to improve end organ perfusion and coronary perfusion by decreasing left to right shunting and thus increasing forward flow. But why did we use tandem? So there were a couple of different options we could entertain. One of them was to leave the balloon pump in place. One can argue that hemodynamically he's stable. However, what was concerning is that if his liver function continues to downtread, he'll eventually have an element of vasoplesic shock, which will be very difficult to treat. Inotropy is another consideration for his RV function. However, given the fact his LV function was preserved, plus we're dealing with an active ischemia, sometimes these inotropic agents act as a substrate for VT, so we didn't really want to use it unless we had to. Impella was also a possibility. However, the tissue around the VSD area is very friable and kind of dynamically changing. So our concern is that if we place the Impella, we'd run into suction events. There's also this theoretical risk of right to left shunting. VA ECMO is a possibility. It could support the RA. We didn't use it because, the RV, sorry. We didn't use it because his oxygenation status was stable, A. And then B, it could significantly increase the afterload in a ischemic heart, which is not something we really want. Thank you.
Igor, which device would you choose, and what do you think about this concept of letting a post-infarction VSD mature? That sounds very thoughtful, but I don't quite know how to pick that timing.
It's very challenging, that's what I can tell you. Well, when we started this years ago, we didn't have really ECMO, you know. We started, I think, tandem hearts in 2003. And so the point is obviously to decompress the left atrium rather than the left ventricle. And the reason is what he mentioned, you know, what the speaker mentioned, that you can have the shunting, obviously you can have debris if you have the machinery, so the mechanical support in the left ventricle. So the goal is the decompress the left atrium. However, that's difficult because it's a steep learning curve for tandem heart placement. So we were fortunate to have, you know, Dr. Carr over there, and he's been 24/7 doing this for years and years. Now, why are we waiting, and how far and how long do we wait for maturing? I think after 10 days, what I've seen from my experience is that the tissues become really not much stronger, but they become strong enough to hold the sutures. If you go right away after the myocardial infarction, which in old days, you know, that was the only option they had, the mortality is still about 40 to 50% post-surgery. However, if you let mature, I mean, let go 3, 4, 5 weeks if you can, hemodynamically, then the mortality is dropped down to like a couple percent. So in these situations, when you have huge VSD and you have mechanical support, obviously you want to go as soon as you can, but not too long after. So our optional time was somewhere when we observed over the years about 7 days to 10 days preoperatively and then go for repair. Now this patient had a little bit more time preoperatively, and the tissues were actually great when we got in there, you know, so there was no surgical issue. I think it was about 2 weeks or so that the patient had the preoperative circulatory support. So if I say it, optimally about a week to 10 days preoperatively, if you can afford it, and then after surgery we always leave the mechanical support in for recovery of the left ventricle, because it has to be conditioned again from deconditioning. Now, in old days, I always left the tandem heart in place But in this patient, we pulled the tandem heart and we just put the oxygenator in between, which is real simple to do. So I think we're changing the philosophy a little bit.
But Igor, I want to comment on this management, because I do think this is one place where tandem heart is physiologically superior, because you're unloading in such a way without too much afterload. My question to you is, when we think about physiology and AV ECMO, pure AV ECMO actually increases the afterload, promoting the shunt. Do you think more the shunt is persistent, that the healing is impaired? Because in tandem, I think your shunt comes down, and does that make a difference?
Well, hard to say because there is no randomized controlled trials, right? However, I think that if you unload the left atrium, it's hemodynamically they do better than if you put the ECMO from initial standpoint. But again, majority of the centers don't have maybe experience with tandem heart, and that's difficult. So you have to go to the experience and expertise and the best option that you have.
But I think I do agree. We've had patients on CP from other centers come over and crashing, put a tandem, and things get better. Now 5.5 is getting interesting because we've had some with 5.5. For some reason, they're relatively stable. Maybe you're unloading enough, but you're right, the tandem universality.
I think 5.5 is a good option. However, if the VSD is huge, there may be a lot of shunt, and you're sucking just the unoxygenated blood into the left ventricle. Indrani?
It's a great case. The question that I had is, do you increase the risk of RV failure the longer you wait? Do you increase the risk of RV failure the longer you wait for repair?
In relations to using the tandem heart, you mean, or?
Tandem heart and VSD repair, the longer you wait.
There is always that risk, but I feel like the RV failure here was because it was a volume issue mediated by the VSD, so I really do think the tandem heart helped, and the patient really needed it. We weren't able to wean it at any point because he was reliable on it.
So Shehab, that was a great case. I thought, obviously, fantastic management, but I think it brings up the other issue for younger people in the room again and again, is that you can get mechanical ruptures as your first presentation. I mean, it's every day you see a guy with a big hole and the right coronary artery with a fresh stent on aspirin and ticagrelor or cangrelor. I think to put a stethoscope and listen and say, whoa, this is something different, does not hurt anybody. And you can hear it. It's not like you can't. And it happens every day. There's just so much that we can prevent. It just complicates the issue downstream for everybody. And so I would urge, there's enough time in your door-to balloon time to put a stethoscope or put a POCUS probe and say, this looks funny, I need to look at it, let's go easy on the DAPT, okay?
Just two quick comments on what Igor said is, number one, to assess LV function in the presence of a large VSD is very difficult. So you cannot say the LV function is normal. That's why you get bitten many times that you do a VSD repair and post-operative the patient's in severe LV failure. And that's what he was talking about, the conditioning. So it's not only important to keep the tandem pre-op, but post-operatively to retrain the LV now, because the afterload of the LV has suddenly increased, is very important, because otherwise the outcomes will be bad. But number two is, the left atrial bypass decreases the left to right shunt, answering Indrani's question. The left to right shunt goes down. So we have not had RV failure with tandem. With other things, you may have it because you don't reduce the left to right shunt. Yeah. Is much higher because of the VA. Yeah.
So, Mr. Jeet, have you had times when the defect is so complex that you have gone to the operating room and used a temporary device to fix it in the OR?
I'm very blessed to work with Dr. Gregorek. We have done all kinds of monkey business in the OR.
I want to know about that monkey business.
Yes, we have done it. There was a case I distinctly remember, had a VSD in a very unusual place, just about 2 centimeters lower the mitral valve. And he taught me a very valuable lesson there. And I couldn't get it percutaneously, and the margins were so close that I was worrying that I was impinging on the mitral valve. And surgically, it was a very big hole, so we said trying to go for the whole repair would go to total artificial heart. Wow. So he said, why don't you partially close it, at least maybe that guy will survive. So he goes to the OR, exposes the ventricle. Now I'm trying to make a hole. Even though the VSD was big, with the wire, I can't cross across the VSD. So he said, come on, I'll show you. Feel the thrill. This is the surgeon. feel the thrill, put your needle there, you will find that's where the jet is. So he felt the thrill, went straight into the VSD, and we closed it, right, percutaneously, without going on cardiopulmonary bypass. The heart was still beating, but it was an open chest, direct visualization. We closed it. We had about 75–80% occlusion. Patient did great. And about, I think, 3 months later, he came back. That's the time he had the full repair done.
Yeah, so working with Samir, we've done the same thing. You know, we go into the OR, we just try to be inventive and do stuff.
Yeah, the other thing that I think was important,